Thank you, Ashish. Our first question comes from Ariel Cohn at CQ Roll Call.
Hi, thank you so much for taking my question. I wanted to ask about a topic that wasn't necessarily covered in your remarks, and that's vaccinating kids under age 16. We've seen that Pfizer has submitted their application for an emergency authorization for their vaccine in younger teenagers. But I'm curious, what should the United States be doing now to sort of get ready for vaccinating teenagers and kids? Like, what sort of preparation should be going on?
Yeah, it's a very good question. I do expect the FDA to authorize vaccinate or really extend the EUA that already has for Pfizer to include 12 to 15-year-olds. The timing on that has been difficult to get, and I've been trying, and I'm sure a lot of you have as well, to get more information about what the timing might be. My assumption has been that it'll happen sometime in May, maybe later part of May, which would allow 12 to 15-year-olds to start getting vaccinated in June. I think the key issue for parents of kids in that age group, and I have 2 kids in that age group, is all about making sure that the safety data is very clear. That's the thing that we always care about for everybody, but particularly for children. And then really thinking about how is that going to get delivered? Is it going to be delivered primarily through pediatricians' offices, which can work? Is it going to be primarily through places like CVS and Walgreens? But then also, how do we make sure we reach communities of color, other vulnerable groups who are going to be always, the access issues are always going to loom larger, and we're going to have to work harder on it. So I think also I want to start seeing some communication out of our federal leaders from the CDC and from Dr. Fauci as we get near about the safety and efficacy data, because I think that'll also build confidence in vaccinating those kids. Based on the data I have seen, I'm pretty enthusiastic, but I temper my enthusiasm by saying I'm not doing a thing until the FDA does its very, very expert and deep dive into this to really help us understand whether this is a good idea. I think it is, but we should actually get expert from guidance from the FDA.
Fantastic.
Okay, thank you.
Our next question is from Felice Fryer at the Boston Globe.
Hi, thank you. Dr. Jha, I wonder if you could talk a little more about the people you mentioned, the 40-some% that are not rushing to get the vaccine. And even in Massachusetts, I think we're going to reach the tipping point where supply exceeds demand. What is the best way for the state to address that? And do you think that it makes sense to engage primary care doctors more than the state has been doing so far?
Yeah, good question. And Massachusetts is among the highest in the country in terms of vaccinating its adult population. It's in the 60s, which is great, but it still leaves a bunch of people out. Again, I wonder if Stephanie, I'm happy to give an answer too, but I'd love to see if Stephanie has any thoughts on this, because she literally has a great piece out today in Stat News about this. Stephanie's strategies on how to get that other 40%, let's say, and then I'll add to your points.
Thank you. I was multitasking. Strategies on how to get the other 40%. First line strategy is to continue to answer questions and understand that people have a lot of questions and not rush. Pressure does not help. It's very clear that communication that focuses on trying to pressure people actually has the opposite result. It's also that our expectations are a little bit out of sync, in the sense that we know for these types of large population vaccination campaigns, right, we never have 100% success rate, or very rarely. And it's important to start thinking about motivations and barriers. As Ashish has pointed out, some of the barriers already around access, right? There's actually a number of pieces out today in NPR and other places that describe in all details, which I know you all have seen. The barriers are different for different populations, right? But we've fallen into a narrative of either blaming Black people, and then we figure out, oh wait, it's not actually that they don't want the vaccine, there's all these other issues. And now we're sort of launching into a narrative of blaming conservative voters, and neither of these narratives are helpful. And I'll leave it to Ashish. I'm happy to talk more later. I know you're all here for Ashish, so I'll leave it to him to keep going.
No, I think that was really helpful, Stephanie. And let me add a couple more things. Yeah, you know, it's interesting. You all have seen analyses of the Trump counties versus the Biden counties. And I find that actually particularly unhelpful because I think it weaves a narrative that is likely wrong and almost surely harmful. Almost surely harmful because it creates an identity around this that says, oh, Trump voters don't want to get vaccinated. Well, if you're a Trump voter, you think, oh, maybe I don't want to get vaccinated. I just don't know that that's helpful for anybody. And the reason why it's likely wrong, I mean, technically right, sure, but what do we know about access in those counties? They are more rural. How do we know? What do we know about how easy it is to get vaccinated in those counties? The higher the barrier, the fewer the people will get vaccinated. If the barriers to vaccinations are higher in the Trump counties, then we've taken access and barriers and converted that into a political identity. So that's one of the reasons why I don't, until we really sort all this stuff out and deal with access much more effectively, I don't think it's a helpful narrative. And as I said, I don't think it's even accurate. I completely agree about the idea of getting this into primary care offices. And this is one of the reasons I was very excited about the J&J and excited about the unpausing of the J&J. It's a vaccine that can sit in refrigerators for extended periods of time. It's a single shot. I can very easily imagine the primary care visit where somebody's there and you just say, hey, by the way, do you want the vaccine? I've got one in the fridge. One shot, you're done. I think things like that are going to make a huge difference. Similarly at CVS and Walgreens, giving people a little bit of flexibility about that second dose. One of the things I often hear from people, they go to sign up and they have to sign up for their second dose. And it's hard for people. A lot of people who are whose shift work is not always schedulable 4 weeks out. They may not have flexibility to know exactly what time they're going to be able to work and what time they're going to be able to come in for their second shot. That presents enough of a barrier for people that they decide that they can't sign up. We've got to build a lot more flexibility into the system. Last point on this, I have been helping a lot of friends and families sign up for vaccinations in Massachusetts. Every single sign up thing requires me putting in insurance information, including insurance ID number and membership number. It's not actually information that lots of people have around them all the time. And given that we're not billing insurance for these things necessarily, it's not really clear why we require that upfront to sign up. If we're going to get insurance, we can get it at the time of the appointment. But things like that just create barriers and make it harder. So the way I've thought about this is, we have the shiny new iPhone. All the people who slept out overnight to get it, that's the group that's gotten it. Fabulous. Now we got to make it like we got to get everybody else who's not willing to camp out overnight. And that's a very different group. They have different needs, different barriers, and we really do have to address them.
Thank you, Ashish. Next question is from Sanjay Mishra at NetGeo.
Dr. Jha, so the question that I have is there is some confusion when the B1617, the double mutant was first detected and possibly where. The sequences were deposited in the GI SAID much before the Indian authorities reported it, so to have discovered. Do you think the sequencing and the surveillance in India was not on high priority? And if we would have been doing more sequencing, do you think this second surge could have been prevented or avoided?
So yes and maybe. So let me explain. Absolutely, India needs to be doing a lot more genomic surveillance than it is doing right now. It has not been a priority. There is some disagreement among experts I'm talking to in India, and again, you may have a different view on this, about how much genomic surveillance capacity India has. Certainly the world has lots and lots of genomic surveillance capacity. And I feel very strongly that India needs to be doing a much higher proportion. Often people ask how much. The UK is the gold standard on genomic surveillance, and they do between 5 and 10%. India does far less than 1%. I mean, 5% or 10%, of course, right now would be 35,000 samples a day. 5% would be 17. Those are big numbers. But we got to do much, much more than we are. I do think if India had been doing that all along, it could have seen the B117 explosion in certain places. It could have tracked B1671 more closely. And what genomic surveillance does is it helps you really track where infections are going and how things are spreading in a way that India was pretty blind to. So I think absolutely needs to be doing more. Yes, it would have been helpful. Would that alone have avoided or prevented or reduced this? The reason I say maybe is because part of it is you also have to act on that information. And there was enough information even without the genomic surveillance, certainly by the end of March, and I would argue even by early to mid-March, that things were heading in the wrong direction, that there was plenty of information for action, and that didn't happen. So I don't know to what extent adding genomic surveillance data, which would have been really useful, to what extent that would have moved the policy world. So it's a maybe on whether this could have prevented it, but certainly yes, on more of it is necessary and helpful.
Thank you.
Thank you. Next question is from Ian Prasad.
Hi there, Dr. Jha. Thanks so much for doing this. I wanted to ask, I think a lot of us, myself included, have been using the rising number of vaccine doses being administered in the US as sort of a metric of success for the country. Does the decline that we've seen in the past couple of weeks reflect the J&J pause? Or is it that we're sort of hitting that ceiling of people who would camp out overnight, as you say, and are eager to get the vaccine? And if we have hit that ceiling, are there other metrics we should be looking for, particularly in the media, to be communicating the success or the frustrations of the vaccination program in the country? Are there things beyond the total number of vaccines being delivered that we should think about looking at to gauge success?
Yeah, it's a great question. Yeah, I think I said this a few days ago and got a little bit of pushback from people, but I stand by it that, like, I think the 7-day moving average above 3 million, we were almost at 3.5 million. I think that's done. I don't know that, I mean, we may have 1 or 2 days where we get 3 million, but I think that number is going to continue to steadily decline. And this is not a surprise, because the primary thing holding us back from doing 5-6 million a day was supply. We have now got to a point where there is plenty of supply in every state in the country. Anyone who wants a vaccine should be able to get one in the next 24 hours if you're willing to work hard enough. That's the problem, is if you're willing to work hard enough, right? So I think the first part of this is communicating that declining number of new vaccinations is not a failure. This is in fact exactly what we would have expected, that the kind of vaccine avid people are done. And now, as I know I've said this before, but I'll say it again, now it's just the ground game of getting everybody else. And that is necessarily slower. So the fact that we're going to have a lot of days of 1 million, 1.5 million, 2 million a day is not a surprise. It's not, in my mind, tragic. It's in fact just exactly what you would expect. And I want to make sure that we don't paint this as a failure, and we don't paint it as somehow showing a lot of resistance. Because it's just, again, as Stephanie said, this is now about addressing access in a very, very different way. How do we talk about it as an ongoing success? Again, in my mind, right, we're at 54% of adults. I want to try to get to about 70 to 80% of adults over the next couple of months. That would be terrific. And because by that time, we will really, again, if the Israeli experience, even well before then, but certainly by that time, if the Israeli experience is of any value to us, which I think it is, we will see dramatic declines in cases across the country. So how to report it? I think talking about the progress we're making on people who have not yet been vaccinated, how we're doing on reaching hard to reach communities, how well we're doing on vaccine equity is really critical. And I'm hoping that along with all of this, we can also track how it's affecting infection numbers and hopefully driving them down. It is a very different narrative and a much more complex narrative than the, how quickly can we drive the 7-day moving average of new doses given up. That is, as I said, it's turned down, and it will stay down and continue to decline, I expect, over the next few weeks.
Thanks so much. That's really helpful.
Next question is from Hillary Brick at Business Insider.
Yeah, thanks for taking my question. I wanted to ask a little more because Ashish, you're always so optimistic, and you said that you think the U.S. and Europe are in reasonably good shape right now. And I'm wondering if, given the events that we've seen in the past, few weeks, India, Brazil, all of that, how worried are you about escape variants sending us back to square one? Is that a possibility you think about these days? And for anyone who's not in a situation like Israel?
Yeah. So let me just say a couple of quick things. I mean, I am really optimistic about the US and UK where it is. UK is in very good shape, US as well, with all the caveats we already talked about with America. Europe is a little bit further behind. And so I think by mid to late summer, Europe will be in good shape. And again, Europe is not a country. And so that means there will be parts of Europe that will be in better shape than others earlier than that. But I do think by summer, mid to late summer, we'll see large proportion of Europe vaccinated. The issue of escape variants and variants that truly render our vaccines wholly ineffective, I've been speaking because that's obviously the nightmare scenario, right? Where they're sort of like, we're all vulnerable again. From all of the conversations I have been having and everything I understand, I think that is a relatively low likelihood scenario. These vaccines generate a very broad set of immune responses, both humoral and cellular immunity. And so you're going to see, like, again, what we see with 351, more breakthrough infections, but not that many. And I think overall, we're going to continue to see more variants that cause more breakthrough infections. But I don't know that we're going to see that the rise of that variant that makes us completely vulnerable. And more importantly, I don't know about more importantly, but as importantly, the question is, are we going to see rise of variants that cause high degrees of really severe illness? And again, I'm moderately optimistic that that will not happen, but but part of this is like, there are some weaknesses of our vaccines. As terrific as they all focus on the spike protein. That's a bit of a problem, and there are plenty of immunologists who brought up that we're putting too many eggs in that one basket. It turns out to be a really good basket, but it's still one basket. And so what I think is going to happen over the next few months is you're going to see the development of new vaccines that are going to be able to both deal with variants a little bit better and may in fact broaden the scope of what proteins they're targeting. And so we're going to continue working on that. All of that is my way of saying reasonably optimistic we're not going to see that one horrible escape variant, but obviously no one is certain, and the best way to avoid that is to prevent all these horrible infections that are happening in places like India and Brazil and elsewhere.
Thank you, Ashish. Next question is from German Lopez as a Fox News.
Herman, you're
sorry. Yeah, sorry about that. Thanks. So I wanted to ask about something you mentioned, which is kind of the inflection point that Israel has seen. I'm kind of surprised how low it's been in terms of like 50 to 60% of the population being fully vaccinated, and the country's pretty much reopened. I guess it kind of is optimistic though, in the sense that like maybe we can get to that finish line sooner, hopefully. I'm just curious for your thoughts on all of that.
Yeah, so I think first and foremost, it really is impressive how like Israel's infection numbers, if we had that it would be the equivalent of about 4,000 to 5,000 infections per day in the United States. And I'm hoping I'm doing the math right on that. But so really, really low numbers of infections. I think we'd all be thrilled if the US could get there. And they have gotten there without vaccinating 90% of the population. Now, I think one of the things that we always have to remember is immunity comes both from vaccines and from natural infections. And Israel's had plenty of natural infections, as have we. And my best estimate is based on CDC data, is America's had at least 35% of its population be infected. And so now you don't get to just add that to the proportion that are vaccinated, because there's a lot of overlap between the two groups. But even if you assume it's random and that there's sort of an appropriate overlap, if we're 54% of adults, we're about 43% of all people. we're probably at close to 60% population immunity. And Israel is probably at like 75% population immunity. That's where you start driving numbers really, really low. So I do think that Israel represents an optimistic picture. Makes me optimistic there will be parts of the United States that are going to be able to get there pretty soon in the next few weeks, next couple of months, certainly. But I also worry about parts of the United States that will not. And Israel's a small country. For a country like ours, let's say you have a place like Alabama, and I pick on Alabama because they have one of the lowest vaccination rates. If they're way lower and generating a lot of infections, it will have spillovers on other parts of America, which have much, much higher vaccination rates. But key point there is, got to look at vaccinations in the context of natural immunity from infections, and then think about the population locally much more than nationally.
Thanks, really helpful.
Thank you. Karen Weintraub from USA Today is next.
Hi, thanks so much for doing this. I've got a couple of questions unrelated. One is about India and what you're seeing going on there now. Why now? Why didn't it explode last year? And why is it happening now? Is it just is it B117? Do we know what's driving that?
This is, Karen, the million-dollar question, billion-dollar question. So I'll give you a few theories. So I certainly think the variants are playing a role. I think B117 is playing a role. And part of it is, it stands to reason, right? Like you just have seen this explosion of cases in Europe. You saw it in the UK when B117 started taking off. You saw it in other places like Ireland and Denmark and elsewhere. And now you've seen it in places like Germany. Germany's largely locked down and still has a lot of infections. So one is that no surprise. That as B117 got to India, you're going to see an explosion of cases. It's just a way more contagious virus than the variant that we were dealing with much of last year. Obviously, there are the other variants that we've been talking about in India, and we don't know to what extent they're driving a lot of these infections. I do think there is some evidence, and certainly this is something that a lot of us have been talking about internally. The seasonality features of this virus are weird and continue to surprise us all. Like for instance, in the United States, we saw this dramatic fall in infections in the US in January, in late January, early February, well before vaccines had a chance to work. And it was puzzling. And some of it was public health measures, more mask wearing, some of it is coming off of the holidays. But there's actually pretty good reasons to believe that some of it was seasonality, that the coronaviruses in the US tend to start falling, normal human coronaviruses start falling in terms of infection rates once you get out of December into January. And so even though it was pretty cold outside, seasonality may have been playing some role. There is a clear evidence that lower humidity plays a role in spread of this virus. And February, March, April are months of lower humidity in some parts of India. And there is some reasons to argue, like Delhi, for instance, has much lower humidity in March and April. And there is some argument that maybe that's playing a role. So we don't know. And then last, but certainly not least, is while things were, I would say, more relaxed than I would have thought was doable in October, November, December in India, I would have thought even at that level, you'd see more cases. Things really opened up. You had these massive events. As I've described, and I've said this a couple of times, Kumbh Mela that happened in India, makes Sturgis look like a small tea party. It's a huge gathering. And it's a very efficient way of both spreading the virus to a large group of people, and then those people disperse all across India and spread the virus all over the country. So I think all of that put together is why now and not in the fall.
Thank you. Next question is from Usaid Siddiqui.
If I can be greedy and ask two more questions. One is the second dose drop off.
Karen, sorry, I have about 80 more questions. Not everybody is using the raised hand feature, so please, one quick question.
The second shot, are you about 8%, I guess, of people nationally are not getting a second shot? Are you concerned about that, or is that actually a good number for adult vaccination?
So I would, of course, would like that to be 0. 92% is really good. And again, I think narratives here are really important. My sense is, and I'll tell you, like, you know, my sense is a lot of this is it's hard to get, like, people miss appointments. People miss doctor's appointments all the time. People miss appointments because life happens. And the messaging that needs to go out right now to people is, don't worry about it. Go get your second shot. I think a lot of people probably are feeling guilty. They're like, oh my God, do I have to start all over again? And we've got to do a much, much better job of saying to people, if you missed it, it's not tragic. People should keep their second appointment. But if you miss it, you can go back and get your second shot at any point. Everybody absolutely needs to get their second shot. We've also had a lot of conversations and stories about all of the horrible side effects of the second shot. I think that has scared off some number of people. But I want to get the narrative here in this right. I don't think it's people hesitating or not wanting to get it. It's hard to get this stuff. 2 shots in a row. I remember when I scheduled my second shot. I mean, I have somebody who has incredible control over my schedule. It was on a day that was horribly inconvenient. And I tried to move it around, and they were like, you got to show up on this day at this time. And of course I did, and I was able to move everything else around. But I just think about, like, that is not an option for a lot of people. A lot of people don't even know what their schedule is going to be like 4 weeks from today. And so we've got to be patient, and we've got to give people more opportunities to come back and complete their second shot.
Thank you, Ashish. So we have about 15 minutes left and about twice as many questions. So next one is going to Usaid Siddiqui. I apologize also for butchering everybody's names. Thank you for your patience with that. And if we can keep the questions short, that would be super helpful so we can get in as many as possible. Thank you.
Thank you. Hi, Dr. Jha. My question was related to India. And what do you think India should do, or what's the best solution for them to mitigate their crisis? How important do you think, for example, vaccinations are at this point? And do you think that countries should send whatever they can at this point to India? Also, do you think that a complete lockdown for India seems feasible at this point, considering, like we saw in the previous last year during the first SARS, that it created a lot of economic hardship for a lot of people? And what do you think is the right balance?
Yeah, I don't think a complete national lockdown is the right decision. I mean, again, the economic cost borne by the poor is extraordinary in that context. We've learned a lot about this virus in the last year. What we know is that it largely spreads indoors when people gather without masks. That's in some ways kind of in a nutshell, what we know about this virus. So we've got to make sure that people don't gather indoors without wearing masks. Therefore, I would absolutely curtail indoor retail, restaurants, shops, as much as possible, anything that has people getting together indoors. Outdoor spread happens primarily when you have large congregations. I would absolutely ban any large congregations outside. It's hard in places in India where things can get pretty crowded unnaturally. I would definitely push very, very hard on universal masking and really trying to get people to upgrade their masks. This is going to be hard for a lot of poor people. Getting people high quality masks, I think, is extremely important. And high quality masks is not synonymous with N95s. N95s are high quality masks, but there are plenty of other high quality masks. And many countries manufacture them. India manufactures masks. I think that is going to be really important. And then I do think, and again, what I'm describing is like a playbook where every one of these things that I'm talking about, none of them alone is going to do much. All of them together is how India gets through this. I definitely believe that at this moment, flooding the zone with lots and lots of testing, rapid testing is critical. Most of the spread happens before people develop symptoms or in the first day after symptoms. If testing is not readily available until later in the disease course, most of the spread will have happened by the time you identify people. Using testing proactively is another important part. Last thought, are vaccines important? Absolutely. Are they going to help India in the next 2 weeks? Absolutely not. But they are going to be, especially if you can ramp up vaccines, especially if you can do it in certain locations in targeted ways, they're going to be the way that India slows this thing down 4 or 6 weeks from now. And therefore, it's worth making those investments today.
Thank you very much.
Thank you, Ashish. I'm going to try to bundle a few questions. So Michelle Smith from the Associated Press and Fran Kritz from NPR, if you could go one after the other, that'd be super helpful.
Thank you, Dr. Jha. The CDC is expected to issue some new mask guidelines today, and I'm wondering if you're satisfied that the CDC's guidance on measures like masks and other public health measures is coming out in a timely way and in a way that's helping state and local public health officials give helpful guidance to their communities.
Okay, and then the next question.
Hi, Dr. Jha. I'm actually reporting from Israel this week, and it's like Mardi Gras here. It's actually a little jarring for people who've been, like me, in your house for the last year. You find yourself sitting inside a restaurant. But one of the things I wondered is, Prime Minister Netanyahu, when he negotiated for the next set of purchases from Pfizer, what he asked for was the vaccine that's needed at that time, meaning not what's on the shelf here. But in the United States, many people, if in fact the booster is needed a year from when you got your first shot, people are going to need that in December, but we haven't yet started to hear about what it will be, nor how it will be distributed. So here we have people who haven't gotten their first shot, who, for all the reasons you say, it's difficult to get the second shot. And now we have an expectation that in the next 5-6 months, they're going to get online again. And how is that going to happen?
Yeah. Okay. Let me start with boosters and I'll talk about CDC guidelines. So I think there's been a lot of talk recently about boosters, including by the CEO of Pfizer, who I have enormous respect for. First of all, I think we should all I have no idea when we're going to need boosters. And I don't think, though I don't know for sure, because no one does, but I don't think we're going to need boosters in like 6 months. I think that strikes me as awfully fast. And to the extent that we need boosters, we will need them at some point. I expect them to happen a year or more down the road. We're going to obviously be tracking breakthrough infections, waning immunity. We're going to have to look for correlates of immunity. There's a lot of science that needs to go into figuring out when will people need boosters. It is also undoubtedly true that when we do get boosters, that it probably will look a little different because we will need to think about how to deal with variants in those boosters. There are a lot of other scientific questions, like if you got the Moderna vaccine, do you have to get a Moderna booster? Can you mix and match? A lot of questions that we are going to be sorting out. And I guess what I have been saying is, because I'm getting asked a lot about boosters, is like, first of all, thank God we just all got vaccinated. Let's focus on getting more people vaccinated. I don't think anybody's getting a booster in 2021. And we will need to probably this summer into the fall start planning for that next generation of vaccines. But let's hold off and do that. And we're going to know a lot more about timing, waning immunity, what the booster should include. Absolutely right of Prime Minister Netanyahu that it's probably going to be something different than what it is right now. But I feel like right now when we're starting to talk a lot about it, at least in some places, a lot of people are getting, whoa, I haven't even gotten my first shot. I'm thinking about my second, and now you're already planning my third. It's a bit of a challenge, I think, for a lot of people. Let's talk about CDC guidelines. So I am expecting the CDC mask guidelines today to say that outdoor mask wearing is potentially important in crowded settings, when large numbers of people gather, but otherwise low risk, unnecessary. And you are going to see, and particularly if you're vaccinated, you're going to see a lot of states starting to pull back mask mandates. The issue of timeliness is really tricky because the CDC is trying to balance a few different things. One is people often will ask me, well, if I've been vaccinated, can I just go into a grocery store unmasked? And that's an interesting question. We can talk about that. But from a policy point of view, that's insanely hard to operationalize because what do? Do you ask your local Stop and Shop to allow people in unmasked if they're vaccinated, but not if they're unvaccinated? And how do you deal with the fact that a lot of your workers still haven't even gotten their shots yet because until very recently, vaccines weren't widely available? All of that made policymaking on this necessarily slower because you had to work to keep people safe, and therefore you had to make assumptions like nobody's vaccinated. You have to make the assumption that that you still have a lot of vulnerable people. I think we're now out of that window, or about to be relatively soon. Certainly today, any adult in America who wants a vaccine can get one. I think that changes the degrees of freedom CDC has, because it also knows that it can't just put out guidelines without thinking about how those guidelines will be used. So I appreciate people's criticism. The CDC has felt a little slow at times. I think they're trying to balance both scientific communication as well as the way it will shape policy. And that necessarily makes them a little bit slower. But I expect them to move more quickly now.
Thank you, Ashish. So next two questions from Abby at NBC News Boston. And apologies, the second one has dropped. Second question has dropped. So Anjali from Yahoo Finance.
Hi, Dr. Jha. This is Abby Nesgoda from NBC Boston. I'll make this quick. You live in Massachusetts. I'm reporting from Massachusetts. Today, the governor is going to make a pretty big announcement about reopening, not just the outdoor mask wearing change, but also, I mean, allowing up to 200 people indoors and 250 people outdoors. And I know we're a lot different than India, but you talked about relaxing measures there and how that kind of led to their situation. So I'm curious if you could weigh in on, you know, this situation that states are in as they're starting to open up, and what you think about how fast or slow we should go on that.
Yeah, it's a really good question. Being here, being from Massachusetts, certainly over the last couple of months, we have seen infection numbers in Massachusetts much higher than the national average. And that's been a source of concern. I have felt that Massachusetts has been too open. And really, it's a judgment call, basically, based on how many people, how many infections, hospitalizations, and deaths you're willing to tolerate. I think we've been willing to tolerate too many of those in the recent few months, and I've been a little baffled by some of those decisions. I do think Massachusetts is making phenomenal progress on vaccinations, one of the highest in the state now. Infection numbers are clearly heading in the right direction, so I feel like that's good, and it gives us some degrees of freedom. No one at this point is arguing that like we need to stay shut down for many more months. The question in my mind is how quickly, and I would say until we get a little further along. I don't know. I mean, Massachusetts is pretty open at this point. The idea of 200 people gathering indoors when 40% of our adults and about half of our population isn't vaccinated that's a pretty high risk event if a lot of those people are unvaccinated. So if you're going to do that among vaccinated people, that's totally different. But I don't think that's what the rules are. And I worry that this is going to further hamper our desire to get infection numbers really, really low in Massachusetts, which is necessary for protecting children who are not going to be vaccinated and for protecting people for whom their immune system can't mount a full response. There's a lot of good reasons to drive infection numbers lower, and I'm worried that this is not going to help.
Hi, Dr. Jha, Anjali here. Thanks so much. Really great to speak with you again. You half answered my question. So the other half is looking at the timeline for the aid to India. Do you see, because like you said, we may not get stuff in time. What is an appropriate time? What should we sort of be looking for in terms of when the US sends, first of all, equipment, ventilators and such, and then the doses? I know they're waiting for regulatory review. So what do you see as an appropriate timeline there?
Yeah, I think time is of the essence. So certainly things like oxygen and ventilators and medicines should be able to move quickly. What do I mean by quickly? Like this week or next. You have the Saudis and the Germans airlifting oxygen equipment this past weekend and happening this week. So I want to see, there's no reason the US government can't move quickly on that. On vaccines, it's interesting to think about safety review. I'm not sure what exactly the FDA is going to do on a safety review on this. These vaccines, the AstraZeneca vaccine has been approved by regulators in India and regulators in Europe and the UK. It's not like it has not gone through any regulatory review. So I think it's fine to make sure that the vaccines are in good shape and that they haven't obviously spoiled or gotten in any way degraded while in storage. That feels very reasonable to me and necessary actually. But beyond that, I'm not sure that there needs to be a much more of a thorough regulatory review of the vaccines. And therefore out in the next couple of weeks would be really helpful.
Okay, quick question from David Mitchell. David, can you keep it short?
Yes, sorry. Yeah, I wanted to ask you about, or just have you talk about the difference in vaccine uptake by gender. There's a pretty sharp divide in Louisiana. It's running steadily around 12 to 16 points. And second, you mentioned something in your discussion about calculating immunity levels overall in the population. Do you think people who have been previously infected should be vaccinated, and can they be counted in the overall percentage of people who are, you know, for herd immunity purposes?
Yeah. So let's talk about the second issue first, and then I'll get to talking about gender and vaccination. So what we know is that previous infections provide immunity. They provide immunity for a reasonable period of time. I think all the best scientific evidence right now suggests that you get a much better, broader immune response from vaccinations than from previous infections. But previous infections give you a reasonable amount of immunity, at least out to 6 months. And my best guess is probably longer than that. So I think we should definitely think about people who have been previously infected as part of a population immunity calculation. Those people absolutely need vaccines. There's a pretty good scientific base to argue that they may only need one shot. This is a strategy that many of us, when vaccines were short, suggested that we consider. The regulators said it was too complicated to try to pull this off. I think that's fine. And so they're going to get 2 shots. There's no harm in getting 2 shots, but they absolutely need to be vaccinated, because we don't think that previous infection gives you long enough lasting immunity, and probably doesn't give you broad enough immunity that immunizations do. You know, on your issue of gender gaps, I know less about it, and I feel like I don't want to speculate off the top of my head. So maybe, David, I can follow up with you separately on that issue, because I just need to look into and dig into the data before I go spouting off about something I don't know as much about, if that's okay.
Okay, we're out of time. Sincere apologies for all the questions we didn't get to. Ashish, do you want to say make some closing remarks?
Sure. So a couple of quick things, and I'll just recap a couple of points. I mean, I think, you know, even this conversation has highlighted what a funny time we are in this pandemic. We are 16, 17 months into this pandemic, and you are starting to see what Fran described as Mardi Gras in Israel, restaurants opening up fully in Massachusetts, and oxygen running out in Delhi. It's a very odd moment. It is easy at this moment to take our eye off the ball if our local conditions are quite good and feel like the pandemic is over. It is really critical for us to remember that this is a global pandemic. And therefore, if local conditions are good, that's fabulous. We really have to continue to work on a global effort to bring this pandemic under control. And I know it's a cliche, but it really is true. While the pandemic is happening and kind of running wild anywhere, all of us are at risk. And it is worth remembering that at this exact moment, these are potentially the worst days of the pandemic. More infections happening right now than at almost any time during the entire pandemic. And we have a long way to go. So I'm really thrilled about where we are in the United States. I worry about pockets of the US. I worry about specific areas over the next couple of months. There's a lot of questions about children. There's a lot about what else we need to do to help people feel more confident in the vaccine and get better access. But we really do need to make sure that all of us are thinking about this from a global perspective and driving a global agenda towards vaccinations, because that is the only way we get beyond this and really get our lives back. That I think will happen. I expect real action from the Biden administration over the upcoming weeks and months on global vaccinations, but we have to make sure that we hold them accountable to it.
And with that, we will close our briefing. Thank you, everyone.
Thank you all for joining.
Thank you very much.